I think we're going to have a wonderful day with a lot of new information, evidence for what is going on in global surgery and for what we need to be doing, or at least our policymakers need to be doing, to actually address the needs of the world. I've always, as a surgeon working in a variety of different countries over the years, been appalled by the disparity in access to surgical care. And so hopefully this commission will be a stimulus to all of us and the politicians in particular to take this topic seriously and to actually do something about it. So without further ado, I'm going to invite Richard Horton, the editor of The Lancet, to address us and say a few words. And once again, I hope you have a wonderful day. Any problems, let me know. If the fire alarm goes off again, it is actually real. And you would have to leave by the rear exit or the two exits in the front and congregate outside the building. Let's hope that that isn't the case. So thank you very much indeed. Richard.
Good morning, everybody. Great to see you here. So many people interested in surgery. Who would have believed it? I'm the worst person to be standing here. I'm afraid I train as a physician. I did one operation in my life, and the result of that operation, a tiny little appendix, is still sitting in a pot in my office. I'm very proud of my one contribution to general surgery. We meet at a moment of unprecedented frenzy. And what I want to do is to try and set the context for what you're going to hear over the next day and also tomorrow. So I'm not going to give any of the secrets of the Commission away. There's never been a time in global health of more opportunity and hope, and yet also fear and anxiety. And those are the kind of coordinates that I want to briefly sum up in the next few minutes. I want to mention 5 transitions that global health is going through that we need to really consider if we're going to translate the recommendations in this commission into practice. The first of those transitions is a strategic one. And it's not about the shift from one set of goals to another set of goals, millennium to sustainable. That's a very superficial change that's taking place, and what the world is not doing is talking about the much deeper meaning of that strategic shift. And what that is, that question is what is sustainability? What does it mean to talk about the idea of sustainability, and what does sustainability mean for health? It's not good enough to use the United Nations definition of simply mixing economic, environmental, and social dimensions of development. It has to be something more meaningful than that. It's about all of us on this planet, not just some of us. It's about taking account of the future as much as it is about paying attention to the present. And we haven't yet begun to translate those ideas, the notion of our interdependence one with another, with the future of human development. Indeed, we seem to be in a world which is resisting our interdependence, pushing people away, using the issues of displacement and migration, immigration, as political tools to fight one another. And we in global health have an opportunity to reject that diagnosis of the world and to argue much more powerfully and strongly for the meaning of interdependence and what we owe one to another. The second shift that's taking place is a technical shift. You can't go to a global health meeting these days without using the word Ebola. And the one lesson of many lessons that I just want to highlight with Ebola is that it has taught us the importance of health systems. But what is it to say that health systems matter? Is it to then talk about universal health coverage? Is it to talk about primary care? Is it to talk about 1 million community health workers, as Jeff Sachs does? Universal health coverage is very fashionable, and perhaps so it should be. But it's no panacea. If you look, for example, in women's and children's health, something like 60% of preventable maternal deaths and half of under 5 deaths take place in settings of conflict, humanitarian or natural disaster. And in those settings, a simple prescription of universal health coverage is not going to work on its own. So if our concern is genuinely with how we're going to embed health systems in our thinking, we need to think much more creatively about how we address these countries that are extremely fragile, and also how we address the fact that 60% of the world's poor now don't live in the poorest countries in the world, but they live in middle-income countries, in countries such as Pakistan, India, Nigeria, China, and Indonesia. A third transition we have to take account of is financial. The era of the Millennium Development Goals was all about getting to 0.7%. It was about overseas development assistance, and it was about vertical financing through Gavi or the Global Fund. That is changing, and changing dramatically right now, and the debate will come to a head in July at the Financing for Development Conference to be held in Addis. We are seeing a massive strategic shift in financing away from external support and more to mobilizing domestic financing. And that will be central to the debates about the Sustainable Development Goals. How we use overseas development assistance will also change. It will be invested more in how we create global public goods, such as the fruits of research and development. And we have to also think about how we take vertical funds and integrate them into health system strengthening. So when we're thinking about a surgical system, so beautifully set out in one of the figures in the Commission report, how do we use the existing vertical funds we have to strengthen those surgical systems? There's a fourth transition which is very difficult to address, especially if you're a big supporter of multilateralism, a big supporter of the World Health Organization, as we certainly are at the Lancet. Exactly 1 week ago today, April the 20th, at 9:21 in the morning, almost exactly the time as it is now, WHO issued a press release in which they spoke of their humility at their response to the Ebola outbreak in West Africa. They confessed to poor coordination, a slow and insufficient response, and confusion in the way the organization at country level, at regional level, and globally operated to address the outbreak. Exactly 1 hour later, just over 1 hour later, at 10:29 on Monday morning, they issued a correction to that press release in which they withdrew all of those admissions of failure. It was very bizarre to see it. And I think almost the only diagnosis you can make when you see what happened a week ago is that WHO is currently an organization going through an existential crisis. And that's shown, again, very, very disappointingly, but it is a reality we have to face as we think about the implementation of the findings of this commission, when John Kerry, the Secretary of State in the United States, signed an agreement to strengthen surveillance in Africa. And he did that between US CDC and who? Was it WHO? Was it WHO Afro? No, it was not. It was with the African Union. And the CDC in Africa will be based in Addis. And in the press release that announced this, there was not one single mention of WHO. I was in Washington, D.C. last week, and the discussion around advisors to US government on global health was very clear. US government strongly supports global health, but it is turning its face away from WHO as the instrument, or at least an instrument, to realize the hopes for global health. The US is going to go it alone in bilateral or regional relationships itself. It has lost confidence, it has lost trust in our only international health agency. So we need to think about what is our response to that. How do we strengthen WHO, strengthen multilateralism, if we're going to really see the findings of this commission implemented? And the final transition is a political one. You can't do global health and think of it only as a technical discipline. It is a political question we have to answer if we're going to get the evidence presented in this report into practice. How are we going to do that? For the Sustainable Development Goals, the magic phrase is means of implementation. And means of implementation is the most hotly contested issue in the SDG negotiation process at the moment. For health, it is around a very narrow set of objectives. It's about tobacco control, it's about research and development, access to medicines, more health financing, supporting a health workforce, and measuring and acting on risks to health. But the big issue that is missing, and this is where you and us and the whole health community has a very important role to play, is the issue of accountability. Accountability is the word for the future. It is about holding all of us, donors, countries, all partners, to the promises and commitments that they have made. And who is going to do that accountability work? It has got to be done by an independent body that is not conflicted with decision-making processes, for example, within the multilateral system or within countries or amongst partners or donors. And that idea of independent accountability is something that we in the health community, we in the academic community, if we work together, can deliver. And I see this report as the beginning of a process where we can strengthen independent accountability to ensure that the promises that this Commission makes are truly delivered. I want to give a few thanks before I close. First, to the incredible leadership team who have put this report together, John Meara, Andy Leather, and Lars Hagenda. Please give them a warm round of applause. They have worked so hard with all the team you see on the byline of the paper over the last 2 years to realize this result, and it is stupendous, and I want to really thank them for that. I want to thank the partners who've supported this work, who you see their logos on the front cover, and you'll see them listed also in the acknowledgements. I'd like to thank the Lancet team that has worked so hard on this, Justine, Zoe, the editors, many of whom are here in the room, who've really worked hard to produce this report in the beautiful way that you see it. I'd like to thank the Royal Society of Medicine for its partnership in making sure that this isn't just a report that sits on a shelf, but we have a meeting where we can really discuss the implications of it. And this is important because this is not simply a paper published in a scientific journal. We want to go well beyond what you have sitting on your laps at the moment. We want to help support the creation of a network that will build evidence and build a coalition that will translate these findings into practice. We want to use the influence and the reach of the scientific community to create a mechanism for independent accountability. And what we dearly want to do is to use the Lancet as an instrument to support the creation of evidence, using that evidence as a platform for advocacy, program development, and policy. I wish you well for the day, and it's a great pleasure to introduce Andy Leather, who's really going to tell you what this report was about. Have a great time today. Thank you very much.